All right, today we're going to talk about a condition that's way more common than you might think, but honestly, it can be really confusing. It's called pilonidal disease. So if you, or maybe someone you care about, is trying to figure this all out, this explainer is for you. We're going to break it all down, the what, the why, and how it's treated, all with some clear visuals to help it make sense.
So, here's our game plan. First, we're going to get on the same page about what this condition actually is. Then, we'll walk through the maze of surgical options, comparing the different approaches. And finally, we're going to tackle that big, looming question of recurrence and what it really means. Okay, first things first. Before we get into treatments and all that, let's get a really clear picture of what we're actually dealing with here. No confusing medical jargon, I promise.
So, at its heart, pilonidal disease is really just about infected hair follicles. What happens is, loose hairs get pushed under the skin right in the crease at the top of the buttocks. This creates this little channel, or a tract, under the skin. And as you can imagine, that can lead to some pretty painful inflammation, swelling, and sometimes a really frustrating discharge.
Now, if you're going through this, I want you to know you are absolutely not alone. It can feel really isolating, but it's actually more common than most people realize. Here in the US, it affects about 26 out of every 100,000 people.
So why does this even happen? Well, one of the pioneers in treating this, Dr. Kariadakis, broke it down beautifully. He said it's basically a perfect storm of three things. You've got loose hairs, you have some kind of force that pushes them into the skin, and you have skin that's a bit vulnerable, like in that deep crease.
You know, it's even got a pretty interesting backstory. During World War II, it got the nickname Jeep disease. Why? Well, because so many soldiers were developing it. All those long hours sitting and bouncing around in military jeeps created that exact combination of pressure and friction that's needed for this thing to start.
Okay, so now that we've got a handle on the problem, let's shift gears and talk about the solutions. The world of surgical treatment can feel like a total maze, so let's try to draw a clear map of the main paths.
After a surgeon removes the sinus, they've basically got three main strategies for handling the wound. They can leave it open to heal from the inside out, but that can take a long time. They could stitch it up right down the middle, or they can use some more advanced techniques to actually move the scar away from that troublesome midline area.
And that brings us to the big question for any patient, right? Is one of these approaches actually better than the others? Let's take a look at what the research has to say.
You know, the biggest difference really comes down to one thing: location, location, location. When you do a direct midline closure, you're putting the healing scar right back into that deep, moist, high-friction zone where the whole problem started. But flap reconstructions, they're specifically designed to move the incision over to the side and flatten out the area. It completely changes the landscape to make it much less likely to have issues down the road.
And here's where it gets really interesting. Look at this data, a huge meta-analysis. That's a study that combines the results from 17 other studies, shows a pattern that is just crystal clear. For every single important outcome, from the risk of it coming back to wound infections, even how fast you can get back to work, these flap repairs consistently do better for patients.
And the conclusion from that massive study? Well, it couldn't be more blunt. The researchers basically say, look, the evidence shows flap repairs are superior, and we think doctors should probably avoid doing these simple midline closures. I mean, that's incredibly strong guidance based on a mountain of evidence.
Okay, so if flap procedures are the way to go, the next logical question is, are all flaps the same? Let's zoom in a little closer and compare some of the specific techniques that surgeons might use. Wow, okay, this is pretty eye-opening. A study directly compared 3 different types of flaps, and just look at the results for the duformantal flap. It had a wound complication rate of just over 9%. Now compare that to over 50% for the other 2 techniques. That's not a small difference, that is a massive difference. And what about for patients dealing with a recurrence? I mean, that's a particularly tough spot to be in. Well, another study found that the Limburg flap had some really significant advantages. On average, patients were back to work more than a week sooner, they reported half the amount of pain, and their satisfaction was way higher compared to those who got the Kariadakis flap. This all leads us to the one thing that is probably the biggest fear for anyone facing this surgery. What if it comes back? But as we're about to see, what we call recurrence is actually a lot more complicated than it sounds.
So let's just stop and ask a really important question here. When a problem pops up after surgery, is it always a true recurrence of the disease? Or could it be something else entirely? And this chart illustrates the problem perfectly.
It plots the recurrence rates from literally thousands of patients. See all those red dots? Those are studies that only followed patients for less than a year. Notice how they're clustered way higher up than the black dots, which represent studies with longer follow-up? This tells us something really important is going on in that first year.
So here's the bottom line. The reported rate of recurrence is 3 times higher in the first year than in all the years that come after. It plummets from over 6% down to just 2%. That huge drop is a massive clue that a lot of the problems that happen early on are being mislabeled as a recurrence when they might just be a complication of the healing process.
And in fact, researchers have broken it down into 4 totally different things that can happen after surgery. Your wound can just reopen, that's called dehiscence. You can have a true recurrence if a little piece of the original sinus got left behind. A perfectly healed scar could get torn open by some kind of trauma, or you could just form a brand new sinus somewhere else. See? Out of those 4 things, only 1 or 2 are really a failure of the original surgery.
This right here is probably the most important takeaway for any patient. Having a problem with your wound, especially in that first year, does not mean the surgery failed. It doesn't mean the disease is back forever. So often it's just a bump in the long, winding road to healing.
And that brings us to our final, and I think most empowering point. If you really want to know how successful a procedure is, you have to look at the long game. The true story isn't told in the first few months, it's told in the years that follow.
So with all of this information, you're in a much stronger position now. You can go to your surgeon and ask not just what procedure they recommend, but why they recommend it. You can ask about their personal outcomes with that specific technique, and maybe most importantly, what their long-term success rates actually look like. Because being an informed patient, that's your most powerful tool on this journey to recovery.